Hello, this is a Brighter Futures film about how research informs policy and changes people's lives. It's my great pleasure to welcome Anuj Kapilashrami from the School of Health and Social Care, the University of Essex. In this episode, we're talking about global health policy. So, Anuj, your expertise is in global public health, particularly in how structure and inequalities play out for people's health. So could you tell us a little bit about your research then?
Thank you, and I'm really delighted to be here. Global public health is a very vast field, and what I focus on, and much of my research is looking at the social determinants and determination of health among multiply disadvantaged populations, and how their social location prevents them from achieving the desired states of health and well-being. And the emphasis on multiply disadvantaged population groups is to counter the trend and the dominant trend in health inequalities research that tends to focus and privilege one axis of vulnerability and not the interaction of people's social and structural positions. That's
might this play out in terms of access to food, but also access to education, security at home, and then actual health systems to support people? I mean, it's the context as well as the specific services.
Absolutely. So it is both the individual level factors, the systemic and structural factors, which can be seen in the context of, say, gender and ethnicity and race, but also the structural conditions of homelessness, of joblessness, of the migration and status, the documentation that people in precarious situations see as a barrier in accessing healthcare services, and how these cumulatively and how these interact with each other to produce or to create the barriers for both accessing healthcare, but also accessing the wider determinants of health, such as food security, such as safe drinking water, education, among others.
And some of these sorts of basic rights, as I think it would be fair to call them, might have been thought to play out more in emerging economies and countries than in industrialized ones. And yet we've seen, despite years of progress, especially in emerging economies, that some of these very same problems have becoming kind of sharper and more apparent in industrialized economies as well.
Absolutely. So I've constantly in my work and also in talks that I've given challenged the whole global North and South divide. And instead wanting to focus on how these disadvantages play out, how these structural conditions play out in diverse settings, whether it be in the context of Scotland, where one of my research was based and where I was looking at these multiply disadvantaged populations and their access to health enabling resources and linking them to a process, to a sort of participatory action agenda that led us to a public hearing on social determinants of mental health, to diverse contexts of precarity that I experienced by migrants who are crossing state borders or national borders and experiencing similar challenges in accessing healthcare or in reporting systems around the violence that they experience. So I've had the privilege to look at these contexts simultaneously through different research projects, so be it in the UK or in Europe, following the migrants' journey by land, or looking at in the Indian context.
So tell us a bit about this question of precarity, the way that people are kind of living and the way that social and economic circumstances can change the nature of their vulnerability. It's not their choice, but they find themselves in different kinds of contexts. How has that been happening?
Absolutely. So in Indian context that you were referring to, it's very, very diverse. It's a very unequal context. So The populations that I am researching, as well as working with very closely, and the communities I'm working with, are ones that are living in chronic states of precarity, in experiencing everyday fragility, in just going about their lives. They are low-income migrants from extremely rural and indigenous areas in India who have moved to the cities in search of opportunities, in search of employment, and are involved in a completely sort of casualized labor market. They're undertaking multiple roles. And there are also people who have moved across borders from the neighboring areas like Nepal and Bangladesh, and are not only experiencing the same levels of precarity and chronic precarity in living and working conditions, but an additional burden of the documentation or sometimes illegality, and sometimes the repressive governance regimes. For example, we saw the Citizenship Amendment Act and the registration of citizenship in Assam, in the northeast part of India, impacted significantly on some of the migrant populations and the refugee populations that we were working with. So
this is the capacity to access, status is changed, and then their capacity to access health services is influenced by these sorts of governance changes.
Absolutely, but it also affects those who are poor, marginalized, and would be the citizens of the country, but do not have the necessary documentation because they've been moving across state borders within India. And their ability to access services, the discrimination, the sort of structural discrimination that they experience within within the healthcare systems, as well as other public systems, is significant enough to prevent them from uptaking some of these services. So working with this population group, whether it be in India or the homeless and those relying on food banks in Scotland, we see similar patterns of structural disadvantage, but also neglect and racism and discrimination that they're experiencing.
Yeah. And if we turn this around a bit and talked about some of the good things that are happening. So these are difficulties for specific groups. Weak governance has made things worse. Systems are under stress. But you also described how bringing people together in Scotland, a more participatory approach, led to some different ways of kind of understanding the problems, and presumably, well, hopefully, in terms of interventions improving people's lives as a result of it. Are there a couple of examples of where things have got better after all, rather than worse?
Certainly. I mean, I would also want to say that while we are talking about vulnerabilities, I am very conscious in both my research, but also engagement with communities, that there is very high levels of agency and resilience in communities. And I'm conscious of the word resilience is being thrown about in development debates in public policy to shift the responsibility from governments to communities. But acknowledging that problem, I also see the strength in communities and the innovations coming from communities themselves. One of the questions that I've been very interested in, both in my work with the communities, but also as a research question, is how do you make participatory processes speak to policy and planning? And that is not a very straightforward question. It's equally complex as asking the question of how you make evidence-informed policy, because it's not a very straightforward and linear process. And some of the examples that I can provide is when we use participatory approaches within the paradigm of participatory action research. And I'm emphasizing the term action here, where you co-produce an action agenda with those participants and with community members. So I've done some tools, including for the WHO, EMRO region, to how to engage communities in determining health service and priority setting in essential benefit and priority benefit packages. Similarly, in the Scottish example, this was a fascinating experience for me and immense learning, where we initiated this participatory action research of looking at how these multiply disadvantaged populations are defining health enabling resources, so what they see in their surroundings as health enabling, similar to the whole asset-based and community asset approach. And then them to identify what the barriers are in uptaking these. And there were multiple groups that were involved. There were homeless, and there were people relying on food banks, experiencing food insecurity. There were those who were unemployed, minority ethnic groups. We had white elderly women, as well as first generation and third generation minority ethnic groups involved in this process. And through these participatory means, we then linked this to policy planning processes, engaged the Scottish Human Rights Commission, the NHS Health Scotland, in discussions and in planning an agenda for action. That culminated into a public hearing that I mentioned earlier. And a public hearing is this accountability tool that I have been involved in India previously as part of the People's Health Movement. And I was almost transposing and translating that idea into a Scottish context. And it was fascinating how it transformed into a entirely different process, where participants themselves decided to present evidence, both as sort of testimonies, but also do a theater, like an interactive play to talk about how what sort of determines mental health, and talked about substance use, alcohol, and linked it to homelessness and structural inequalities.
So if we can get the kind of platform for this engagement right, then it's creative, as you've just described, brings further ideas forward, and then needs pushing or translation into the policy context to get policymakers to recognize the value of that. And you've said how difficult that is, but if you were to summarize a couple of key policy lessons from this kind of research, what would be at the top of your list?
Several. So that process, of course, led to public hearings being identified as a meaningful tool for other issues. So there were a number of other policy areas that then the public hearing tool was being utilized. I also want to link this to the wider processes of social movement building within which my research is embedded. So when we talk about research leading to impact, it's also important to acknowledge that wider mobilization that is necessary for research leading to impact. So for example, one of the outputs that we had from this work was a People's Health Manifesto, where people determined what their priority areas are. And we used the People's Health Manifesto as a tool to lobby political parties and the then government. Our manifesto was picked up by some of the political parties into their own election manifestos and approach on health inequalities. So some of the lessons that we've learned is that engaging all the stakeholders at the very start of conceptualizing the problem. We're following suit in the context of a recent project that I'm launching, which is looking at this syndemic of mental health and violence among migrant populations in precarious contexts. Engaging those policy stakeholders from right at the beginning, but also building their capacities. We often talk about building capacities of people to engage with these processes, but building capacities of planners and policymakers to engage with these processes and be open to hearing what is working, what is not, and under what conditions.
Yeah, multiple voices.
Multiple voices. Multiple languages. I mean, that's been one of the biggest challenges. Even we as academic, and I refer to myself as an academic activist, we have to be conscious of the kind of language we're using when we're engaging, when we're working with communities, and how we translate that into policy discourses. That's an entirely different language as well. So working across these epistemic sectors and zones is for me one of the key learning from this process.
Anuj Kapilashrami, thank you very much indeed. You've been watching a Brighter Futures film short. For more on how research it changes policy and informs how we can improve people's lives, pop over to our sister podcast, Louder Than Words.